waste 2 minutes, and then by then everybody will be in the room.
Okay.
Welcome, everybody. This is the Brain Tumor Awareness Month 2018 webinar series, conducted by the JFK Medical Center, Central New Jersey Brain Tumor Support Group, and the Musella Foundation. Tonight's special guest is Dr. Henry Friedman. He's a neuro-oncologist, both adult and pediatric, from the Preston Robert Tisch Brain Tumor Center at Duke. Dr. Friedman, you could start.
Hey, everybody. It's good to have you join in. What I'm going to do is basically talk a bit about the sort of standard approach. I'll focus on glioblastoma since that's the tumor that everybody seems to really focus on. But then if there are any questions at the end on other tumors, I can certainly manage to talk about that as well. So for glioblastoma, excuse me, which is the tumor that I think most of us hear about in the newspapers with a number of famous people having gotten them, and they always generate at least a little bit of focused attention. Glioblastoma is a tumor that is the most common of the adult primary malignant brain tumors. It's about 13,000 in this country every year that are diagnosed. It is considered to be lethal. Too often the internet basically says what most programs say, which is that it is terminal on diagnosis, which is completely untrue. There are more and more, a minority, but more and more patients who are surviving and being cured of glioblastoma. A lot of my colleagues don't like me to say that. I think it's wrong, but the other ones are wrong. There's no question that people are surviving this tumor in ever increasing numbers, though it be still a minority. The standard approach to taking care of somebody with a glioblastoma is to do surgical intervention whenever possible and to resect as much tumor as can be done without giving anybody an unacceptable deficit. And there are a lot of deficits that sometimes people think may well be worth like a visual field cut. That may be an acceptable deficit, maybe not. But there's no question that maximal tumor resection is a pivotal first step. And there are some programs where people just get a biopsy when a better surgery could be done, and that's just not acceptable. So for us at Duke, for example, when we get a patient referred to us, we will always look at the MRIs first. If it was a biopsy, see if we can do surgery. If it was a surgery, see if it was adequate. And if it wasn't adequate and we think we can do better, we will proceed with that. Radiotherapy has been a known intervention that has proven merit for a very long time, 30, 40 years. It goes back a long time, and it unequivocally increases the survival of patients with this tumor. Chemotherapy used to be a nitrosourea like CCNU or BCNU, contributed in a small way in the early studies done in the 60s by Mike Walker. More recently, in the 90s, temozolomide came along, which makes a additional small step in the outcome of the disease. And a number of studies have shown that if you look at the MGMT or AGAT, either way is correct, 0,6-methylguanine DNA methyltransferase, you can make a statement as to how patients are likely to do. It's been overused and overinterpreted. It has meaning in patients who are under 65 or 70 as a prognostic feature. Take 100 people whose tumor shows that they have MGMT present, and those who show that it's not present. And I should be very careful how to explain. Most people are using a method that looks at the promoter, the place on the gene that really turns the gene on. If it's methylated, then the gene is turned off. You don't get this protein. If it's not methylated, then you do get the gene turned on, and so you have MGMT present or not. Some people use a protein assay, a immunohistochemical assay, and then it's just totally a different interpretation. So I'm going to work with the more commonly used terminology, methylation or not methylation of the promoter. If the promoter is methylated, gene is turned off, and 100 patients who have that versus 100 patients who have a unmethylated promoter will do better. But if you go to the individual patient at the bedside and try to use it as a prognostic tool, it has no merit. Can't be done. It's not predictive. And so people who say, well, I'm not going to give somebody Temodar because they're unmethylated are wrong. The only way it has value in the under 65 would be somebody who was looking to go on a trial and they need that data to have trial entry, whether it be methylated or unmethylated. There, it makes sense. Over 65 to 70, it looks like it may well be predictive in that patients appear to respond or not respond in large part based on their MGMT status. But a recent paper just came out saying that it really didn't have a whole lot of value even in that age population. So I think right now there's no reason not to use temozolomide in someone independent of their MGMT status unless it's because of a trial, in which case there may be reasons to not use temozolomide and use something else in a trial setting. Other additional weapons that are out there now, Gliadel has been out there for a long time. It's simply a polymer you implant in the tumor bed at resection. It has a modest increase in survival for newly diagnosed or recurrent disease. It's really releasing BCNU. It's a BCNU embedded polymer. It's never really caught on in the field and doesn't get a lot of play for a lot of reasons. Part of it was that there were 4 or 5 drug companies that had ownership rights to it. It was never really adequately promoted, and at this point, it's very rarely used and never at a major academic center, as far as I can tell, just used more in the community. Probably the most controversial topic out there is Tumor Treating Fields, Novacure. The data for recurrent disease was no better than for CCNU, although the toxicity profile might have been better. In newly diagnosed patients, it appears to increase median survival, and there seems to be a higher survival at 5 years of 13 versus 5%. And yet, almost every academic center does not promote it. That's because there's a lot of concerns with the way the trial was conducted. There's a lot of concerns regarding the approval process that it went through. Nevertheless, it is approved by the FDA, approved by most medical insurance companies, not by, at least until recently, unless it's changed, but I don't believe it's been approved by CMS either. My last check was a couple of weeks ago, Centers for Medicare and Medicaid Services. And so the way we approach it is, if a patient brings it up and wants to use it, we'll support that for them. If they choose to not use it, we certainly support that. You can't use it if you're on a clinical trial. It's a confounding variable. But other than that, I don't think it's ever going to get a huge market penetration, because shaving your head 18 hours and wearing a battery pack is a turnoff for a lot of people. Nevertheless, we are, at our program, certified to use it. We do use it under certain rare circumstances. I think it's more used in community hospitals than it is in academic centers, but it is approved, it's out there, and a lot of people do believe in it. And I won't be any more controversial than that about the agent. Bevacizumab or Avastin, I have skin in the game. Our program was the first one to show its benefit in patients with recurrent GBM and high-grade glioma. I led the trial that did it nationally, got an accelerated approval. It did not, in recurrent disease, it did not show a survival benefit in the newly diagnosed, but the problem was that it was a randomized study. You either got radiation Temodar, bevacizumab, or radiation Temodar, and if you failed radiation Temodar, you could cross over and get bevacizumab, which 40 to 50% of people did on the 2 different studies that were done, RTOG and the Roche study, Abiglio. Then there were some studies in recurrent disease that seemed to show it was better than CCNU, when given with CCNU compared to CCNU alone. Then other studies, an expansion of that study by the EORTC showed that there wasn't a survival advantage. Every single study has shown an increase in progression-free survival. On the basis of the totality of the data, the FDA ignored their usual rules, which says if you don't make your landmark achievement in newly diagnosed patients, it's going to be removed from the approval process for recurrent disease. That was not done. It got a full approval. I think that's because there's a lot of people who really believe, as I do, that it's a profoundly active agent. That's really the established field of agents that are out there. So then you say, well, I want a clinical trial. What can I do? a lot of clinical trials looking at a lot of different arenas. Vaccines are very much in vogue. A number of them have shown to be disappointments, including our V3 vaccine, EGFR V3 targeted vaccine, which was ultimately licensed by Celldex. There are other trials out there that are not really moving forward. Nobody yet has truly produced a vaccine trial that is unequivocally doing some results that are going to lead to, or unequivocally lead to an FDA approval. Checkpoint inhibitors, making huge differences in patients with lots of other cancers, like President Carter with his brain mets. That therapy is remarkable in lung cancer and in renal cancer. The problem is that it's about 30 to 40% of patients who respond, and when they do respond, they do great. That's in other cancers, and all the others fail. In glioblastoma, it has not made a mark yet of any kind, none. There's really no data in any of the so-called checkmate studies or other studies that have shown that it has changed the outcome of the disease. So what people are now saying is, well, if a checkpoint inhibitor revs up the immune system and a vaccine is supposed to rev up the immune system, then maybe the two used in combination are going to be meaningful. And that's what a lot of different people are working on, including us, to see if that combination can prove a meaningful intervention. I think it's difficult to give a talk and not talk about the modified polio virus, which is our work. And that's clear that using a modified polio virus, which is injected into a recurrent GBM, has to be the right size, right location. We now have, going out 6 years, a 20% plateau of survival. And what that means is that when recurrent GBM occurs, you typically have a survival when you hit 2 to 3 years of 0%. Median survival in immunotherapy is not a very good endpoint. Polio produces only a couple month increase in median survival. For all of immunotherapy, you have to look at the tail, the curve at the end, to see how many long-term survivors you have. Polio is now in phase 2 trial. It's open in children. It's going to be open in grade 2 and grade 3 tumors. It's going to be open because it binds to a receptor on every solid tumor except Burkitt's, and melanoma, and breast in a couple of months, probably a month or so. So it's getting a lot of play. And naturally, what we're going to do is combine it with a checkpoint inhibitor. That's the next study down the line to see if we can make it even more effective. Other interventions that are out there that appear to be meaningful. Nothing that comes off the top of my head, unless I'm missing something, which I'll be glad to answer on a question, but I have no doubt in my mind that the best way to treat a glioblastoma is to be at a center of excellence and get on a clinical trial. If you can get on a clinical trial, I think that really increases the chances of a better outcome. Also, when you're at a high volume center of excellence, all the papers that have come out say you do better, you live longer, and you live a better quality of life. That's true here, and that's true in Europe as well. Studies have been done in both continents showing that benefit. If you can't get on a clinical trial, then I think the standard approach of radiation and Temodar, which is used following surgery, is a very reasonable approach to use. It does have some long-term survivors, but not a high number. And you can build on that if there is recurrence, which there usually will be. But it's still therapy that is the best that we have to date in the treatment of the tumor. So surgery, maximal surgery, as I talked about earlier, radiation, Temodar. Now combining them all, it's really Roger Stoop who has put that approach together. He was not first to demonstrate the benefits of temozolomide. Other folks were, but he was the first to put it into a combination for newly diagnosed patients to show that you could actually do better than with radiation alone. The problem is that there is an overwhelming nihilism that Al and I battle every day. There are patients who are told from the get-go, you don't have any chance of doing well. You shouldn't be treated for this tumor. It's very reminiscent of the way children were treated frequently in the late 50s when they had leukemia? Why put them through blood transfusions? Why put them through painful procedures like bone marrows? Why do any of that? And today we cure 90% of children with leukemia. So that there's no question that we're chipping away at the problem slowly, but step by step. And I have no doubt that the incidence of patients with glioblastoma who are being cured is going to increase year by year as more of these interventions come out and we begin to understand more about what they might be doing. And so I think that if you have doctors who believe that it's hopeless, then you need new doctors. If you have a program that believes that there really is nothing more to do for you, you need a different program. If you're at a community hospital and there's any way to get a academic center at least governing the care and working with a community program, I think you increase your chance of doing well. If you believe that it is hopeless, it's like entering a basketball, I'm a basketball nut, competition, believing you can't possibly win, and you won't win. If you go in thinking you probably have a shot at winning, then you may well win. And so there's lots of different approaches, there's lots of different people, there's lots of different institutions that are out there that are doing this. There's only a handful around the country that truly are what I would call brain tumor centers that have the right attitude, and at least for most of their faculty, and tend to want to tell someone you are curable till proved incurable. And even then, I think that there are patients who, when they recur, still can be cured. I think we're doing that with polio now, although it's a little premature to say that. But I think that we are beginning to demonstrate that. Looking at the time, that's about 15 minutes. And I really want to leave a lot of time for questioning rather than for me just to do a monologue, because typically when I do this, there's always a ton of questions. And so I'm looking to see that there's 30 participants, and I hope that there are a ton of questions right now. So please fire away.
Okay, there's a bunch of questions on Facebook and here.
Good.
Let me start off with a simple one. You were talking about the PVS Ripo, and it had a long tail of about 20% of the people did well years down the line. There's been a few other vaccine trials that also had long tails of, say, 20% long term. Would it make sense to combine a couple of these together? Would you get like 20, 40, 60%? Or would they be the same group of 20% of people who would respond?
No, I think there's a real rationale for combining different vaccines. The problem is that, as you know, when you combine one investigational agent, it's difficult to get FDA approval. It's difficult to get different parties to work together. So we've talked about that, but I think that for now, with PVS Ripo, we're going to be moving more. Right now, for example, our randomized study is PVS Ripo plus minus one dose of CCNU, because CCNU, one dose decreases Tregs, which suppress the immune system. So it's a backwards way of basically augmenting the immune response. But I think what we really want to do is the PVS Ripo and a checkpoint inhibitor. Will we ever consider another virus? We might, but it would probably have to be a commercially available, or rather a commercially available vaccine to make it practical. But yeah, I think you're right. I think that if you're hitting two different targets, why not?
Okay. Does methylation status impact the outcome in the polio vaccine trial?
No, there's neither methylation status so far in the phase 1 trial, nor does the Avastin pattern of failure. I don't have hard numbers with me, but in general, it doesn't look like we've seen any difference. But that's not something that has really been analyzed to the point where I could, say this is going to be something that I can stand on. But the gut feeling we have is no.
Okay. One of the other hot treatments lately has been the CAR T cells. Can you just talk about that for a minute?
Yes, CAR T cells, which has made a huge splash in childhood leukemia lymphoma, is basically to design T cells to attack specific targets, antigens, in a tumor cell. In leukemia lymphoma for childhood, it's curative. It's a huge break. In the GBM population, the only target that I'm aware of that people have used has been EGFR V3. We have, was open for newly diagnosed patients that we really closed because of funding issues. But we know that the Philadelphia program, which is the world's leader in CAR T-cell therapy, and also City of Hope have done CAR T-cell studies, far more patients treated in the study in Philadelphia, and the results to date have been disappointing and pedestrian. It may well be we need a different antigen target than EGFR V3 to make this therapy meaningful. It's very, very exciting therapy. It's very dangerous therapy. There can be deaths from this, and there have been. And I think that you've got to really be paying very close attention to the side effects that you can get with this. But it's certainly something that we're going to open, for example, a V3 study in recurrent GBM and see if we can. We will get that funded in a different mechanism, see if we can really make some progress in that arena. So I think CAR T-cell therapy deserves further evaluation. I'd like to see more people using using different targets than simply V3.
Okay, which poliovirus vaccine trials are open right now? For what?
Okay, so the major trial that's open is a randomized phase 2 trial for recurrent GBM getting poliovirus or PBS Ripo with or without 1 dose of CCNU. It is open at Duke, and within the next month, I hope it opens at MGH, at UCSF, and at Boca Raton Regional Hospital. Those are the 3 additional sites we're going to open. We have a trial open now for pediatric malignant tumors, brain tumors, not just glioblastoma. They have to be, I believe, supratentorial. It may be actually infratentorial as well, but not the target we all really want to go after, DIPG, because we're still concerned that the toxicity, because you get an inflammatory response with this PBS Ripo in the brainstem, might be dangerous. Although there's a lot of discussion at our institution about how we might satisfy ourselves that it's safe to do it and get there, because obviously that's a target we're all after. DIPG is just such a challenge, and nobody has an answer for that yet. We are about to open grade 2 and grade 3 recurrent glioma in adults. We are about to open melanoma and recurrent melanoma and recurrent breast cancer, but those studies are not yet open, and that would be things we're doing, but not really us, but people that we collaborate with who take care of those kinds of patients. And that's really and of course the one that's coming as soon as possible is the one where we're going to be doing poliovirus and a checkpoint inhibitor, where we're going to give somebody a checkpoint inhibitor. This is a recurrent disease. Then they're going to get the poliovirus treatment. Then they're going to get surgery 4 to 6 weeks later, so we can really diminish any concern for an inflammatory reaction. And they're going to stay on the checkpoint inhibitor for a year. That's the study of all studies we're dying to do in the adult population. And we're almost there yet, but not quite.
Okay. Bonnie asked, she just started the standard treatment. She's in the first week. How likely is it that she's going to lose her hair? And also, what is the best way to treat constipation?
Okay. So in terms of losing your hair, there's a reasonable likelihood you'll lose hair within the radiation field itself. Temozolomide can produce some hair thinning, but typically not a major problem. Constipation, it's interesting. There are a number of different strategies for that. And typically when that happens, I turn to my nurse practitioner or my nurse clinician and say, hey, will you help this patient with constipation? Obviously, there are some foods that can help with that. But I'm going to defer that question and should be able to answer it better to the people that I work with who handle it every day.
It's funny, we laugh about it, but that seems to be one of the #1 problems that I'm hearing.
Absolutely. The biggest problem with temozolomide is constipation.
Right. Okay, another person, William C. He's in the 8th month since his GBM tumor was completely removed. How typical is it that another tumor will recur, and about how long would that take?
He's 8 months out, I assume still on temozolomide, or did he do a 6 month? Well, he probably is either, I don't know if he did a 6 month or a 12 month plan for the temozolomide.
That's actually the next question, but keep going.
Okay, so typically the further you go out, the less likely you will recur, but there's still a substantial likelihood of a recurrence in the opening number of years after treatment of a glioblastoma. So I think you do what almost everybody does. You live scan to scan. I mean, you feel great after a clean scan, and as it gets closer and closer to the next scan, you start to get really uptight.
Okay, I was going to ask about the Timidar. First, alternative dosing schedules, like every day for a month instead of 5 out of a month. And also, for how long would you use a standard? Is it 6 months, 12 months, 2 years, forever?
I don't think anybody's defined the optimal schedule. The schedule that came out of the phase 1 study, was 5 days on, 23 off. Then metronomic Timidar, which is so-called, I don't like that word. Boston people coined it, and basically it's because it never skips a beat. That's how it was named. But in any case, we tend to use 5 day on, 23 off as the standard approach. If people are having too many side effects from that, the side effects can be modulated by going to the daily therapy. Nobody has ever shown a difference in outcome. We tend to treat based on the age and the protoplasm and the side effects. So if I've got a 30-year-old who's ready to move on with their life, and maybe they want to have a baby, and the scan looks clean, or if the scan is not clean, the PET scan is cold, we would be willing to stop. If I've got a 79-year-old where I know that if they fail therapy, if they recur, they're never going to get put back into remission, or it's very unlikely, I might treat them forever. There are other patients who just refuse to come off. They want to go 2 to 3 years. So I don't think that there's a real answer. Now, there was a paper that came out in the Oncologist that basically said 6 months was as good as anything, and longer was harmful. And I so totally disagree with that paper. It was a retrospective analysis. I think it has zero meaning and pay no attention to it. And so we tend to treat typically for a year, but we will go longer under certain settings, depending again on the age of the patient and the protoplasm, how they're tolerating it, and basically what their life goals are. There's no right answer. 12 is our standard, though.
Okay, there's always a concern that it would cause leukemia. How common is that?
Very rare. It can be associated, it's a methylating agent, it's carcinogenic, no question about it. And it can definitely cause myelodysplasia, which is pre-leukemia, or leukemia itself, but it is still exquisitely rare, but it does happen. On the other hand, if you're treating a malignant brain tumor, you don't think about that. If you are saying, well, is there a true dose relationship between the likelihood of a second malignancy and how long you're on the offending agent, I don't think anybody has an answer to that. I don't think we really know that. I do know that it produces mutations extensively, and there are more mutations in temozolomide-treated patients than those who did not get temozolomide or at the time of diagnosis. But it's not like we have a lot of other great options right now. If I could treat patients and never have to give them a methylating agent, I would love to do that because it is carcinogenic. But again, it depends on what you're treating. Would I use it to treat a cold? No. Treat a rash? No. Treat a GBM? Absolutely.
Okay. Is there any way to avoid the use of radiation, either now or maybe in the future when we get slightly better treatments?
I don't think there's a way to avoid radiotherapy now. I know people have tried. For young children, I think there are protocols like Head Start where we don't use radiotherapy because it's so devastating. In the adolescent adult patient, I think there's no way around it. Some people believe proton therapy is less toxic. That may well be true. I think that in certain settings, proton therapy may be less toxic, but no one's really proved that meaningfully, at least in the adult population with glioblastoma. I don't know that we're going to get to the point where you don't need radiotherapy. I would certainly hope so, but I don't see that coming in the next short span of time.
Okay. I had a couple of questions about Optune. I know you talked about it already. I just want to point out one quick thing. There's two FDA approval pathways for devices. It's the 510K, which is easy. It's basically a couple pieces of paper and anybody could get it. That's if you have a device that's very similar to something that was approved before.
Right.
The pathway is the PMA, which is basically the same as a drug approval pathway. I testified at the meetings for the Optune and Avastin, and it was basically the same exact thing with the same standards of proof, the same experts were there, and they battled it out the same way as Avastin. And the results were basically, for newly diagnosed, the results were better than the Avastin trials. I know you mentioned you didn't like the clinical trials for Optune. The biggest problem that they seem to have had is there was no placebo. So people either got the device or they didn't get the device, but they didn't make them shave their heads and wear electrodes. I was actually in the discussions when they were designing that. And I was dead set against having a placebo device because it's so much trouble to wear that if you're going to go through the trouble of putting on these things, shaving your head, being out in public, and not getting the treatment, I thought that was kind of cruel. I thought it was kind of cruel to have a control group in the first place, but they needed it. But with the results that came out, the latest results, if you look at subgroups, which I know you can't always rely on subgroups, but if the people who used it 90% or more in the trial had a 29% 5-year survival compared to a 4% 5-year survival in the control group, there's no way you could design a trial to show a difference like that. That was just my quick point. So the question is, what is your view of using Optune with recurrent GBMs?
Well, I have no problem with people who want to use Optune in any setting as long as it's not a trial. You can't use Optune or anything that has any potential or real activity in a clinical trial because the trial is confounded. But if we're talking about non-trial patients, I don't have a problem with anybody using Optune at any time. It's a question of, am I going to actively push the product, or am I going to really accommodate those people who are interested in using the product? And our program has chosen the latter position, but we don't deny access to it. And if somebody wants it, we will promote it. There have been certain situations where I've promoted it, where, for example, someone's bone marrow is such that they'll never tolerate any kind of form of therapy. And then I think that that is
The perfect case.
It's the perfect case to use it, for sure. So I'm not, the one thing I think I'm pretty confident about is I don't think that the standard of care is going to include Optune so that it becomes this control arm for the further studies that are moving forward. I don't think the academic institutions in this country are going to do that. I'm confident of that. But I do believe that there is enough out there that if somebody wants to use it, we certainly will support that use. But on our own, with the exception, again, I think of a marrow-depleted situation, we don't tend to push it. But again, I'm certainly listing it as an agent that is FDA approved on the basis of activity that's been demonstrated. I wish other things had been done differently with this trial. I wish things had been done differently with the Avastin trial, which I'm guilty of. We didn't have a control arm, and that set us back a very long time in the recurrent disease study. But again, when I was doing it, they wanted me to do CPT-11 with a 5% response rate as the FDA as the control arm, and I refused to do it. Who knew that CCNU would emerge as the control arm for almost everything now, because it's proven better than a number of things like enzastorin and cediranib, and it's an excellent control arm for a lot of different trials. So I don't think we're that far apart on Optune. I think it's a function of the degree of passion with which you promote it, not whether or not you believe it has some benefit.
Okay. Last thing I wanted to add on that was you mentioned that Medicare doesn't pay for it. We have a program through the Musella Foundation that helps people with co-payments. Between our program and the assistance program at Optune, every single Medicare patient that we came across so far was completely covered with no out-of-pocket expenses.
By Medicare or by you?
It's by us and the company. So Medicare is not covering it right now, but it doesn't cost the patient anything, and they could get it. So it's not a problem.
Well, that's good to know, because we've had Medicare patients, and that's been a challenge. But I know that the company has a very good program. I didn't realize you were contributing to that as well. I think that's excellent.
What they do is they charge you based on your income, and most of the people, it's like $250 to $500 a month, and our program covers that $250 to $500 a month for the whole year.
Okay.
So it works out between both programs. That's free.
So I want to throw a question at you in vain now. The question is, I was the one with my pharmacist, PharmD, and one of her interns who wrote the letter to the cancel letter alerting everybody to the monstrous increase in price of CCNU,
Yeah.
which was rebranded. I then was the one with Duke who took it to Pete Loftus at the the Wall Street Journal and got the Wall Street Journal to publish an article exposing the behavior of this company in Miami. And to my knowledge, nothing's changed. They're still charging an outrageous amount for a drug that used to cost virtually nothing simply by rebranding it and making it.
It's funny because now anybody could produce that. Nobody chose to because of the economics. There's a group of hospitals that got together recently, and they're about to start up a generic processing company that will take all these very expensive drugs like Gleason and just make them available basically at their cost.
Pivotally needed, because I've had patients now who can't afford the drug, and it's just criminal. And then, of course, this company's CEO has done some other things that are not very kosher, to use that word, and I don't want to get into it, but it's a big problem because CCNU is a commonly or Gleason is a very commonly employed drug, and it's very disappointing that the price was just jacked up so incredibly.
Yes, I completely agree. Bob asks, he says, my wife is a patient at Duke with another doctor. Do you actively look at each patient's chart with the other doctors? I assume you have a tumor ward, correct?
All right, so the way it works at Duke is it is a group practice, which means no one doctor has the only say on a patient. But we discuss those patients that are brought forward to the team to discuss. We don't discuss everybody. However, before anybody new gets into the program, their MRIs are almost universally reviewed by Alan Friedman, and I have the information. He looks at the scan to make a decision whether surgery is appropriate when a biopsy was done, or surgery is needed when a first surgery was done, or for recurrent disease, whether we have patients who are candidates for polio or something called D2C7. So we play a role in all the patients, but on the day-to-day, week-by-week care, most of the attendings are working on their own with their nursing team. And if there's an issue where they have a problem, they'll bring it to the other attendings. But we see 820, 830 new to Duke brain tumors a year, carrying thousands upon thousands of patients. For everybody to discuss every patient is not feasible.
Okay. Are you familiar with the drug Val-083 for unmethylated GBM patients?
No.
It's similar to Timodol, but it works at different locations, so theoretically, it shouldn't make a difference if you're MGMT methylated or unmethylated. It's in a clinical.
How far into the evaluation process is the drug? I don't know.
I think it's only phase 1 trials now.
Okay, no, I have not worked with that.
Okay. You mentioned the drug, Celldex drug a while ago. That was also another one that had a long tail, and I know some patients who are alive today who were in the trial 7 years ago. Yet it failed, so nobody could get the drug anymore. Do you think that might be one of the vaccines that, if we had something like the right to try, where you would take a vaccine like that, which had, I think it had absolutely no side effects. It was a simple shot in the arm. One of the other treatments?
I was profoundly disappointed with the V3 vaccine. It was a commercial decision. I understand why, but exactly what you said, there is a tail there of patients who seem to do really well with the vaccine. But the other problem was not that the vaccine didn't reproduce prior results in the one-armed studies, whereas phase 2, but there was a better than expected outcome in the control group. That's what really doomed the study. I think the V3 target remains a target that I'd love to see explored. If right to try can allow it, but you got to be able to get it. No one's making it now, as far as I know. V3 is the vaccine is not available.
Sure, but the patent is probably expiring soon.
The patent is probably expiring.
What do you think about gliolin? That's the dye that they inject before surgery to light up the tumor?
I think for some surgeons that's beneficial. For other surgeons, I think that's less beneficial. I'm not convinced it makes a difference when you're really at the top tier of surgeons who are getting gross total resections. And is there going to be a rim of active tumor cells? Always. I think for other surgeons, it might be a very additional positive benefit. But in general, I don't think it's something that everybody needs. I think some people are using it, not everybody.
I think it's just launching this month. Heather is asking, her husband has a grade 2/3 anaplastic astrocytoma. He did radiation with temozolomide with good results, but then the next course of Temodar wiped out his white blood cells, and he has to stop Temodar. His tumor is unmethylated. What other options would there be? Let me rephrase that. If your blood counts are too low for Temodar, what do you do?
You don't have a lot of choice. If they're too low for Temodar, there's almost no chemotherapy out there that isn't bone marrow toxic. And so you're really in a difficult position. I think if we had somebody who was in that story and had surgery, radiation, Temodar that led to ablation of their bone marrow and could not continue with more therapy, I think right now we would probably watch them for lack of having a better intervention. The only other thing you could do is try to find somebody who had a vaccine trial where counts are not going to be an issue, where you could get on the vaccine trial, either getting on it as a patient, which is unlikely in that setting, or getting on it on a compassionate release, compassionate use basis. And that's also very difficult to do.
But wait, if the white blood cells were way down, don't you need your white blood cells to make the vaccine work?
Well, I thought you were talking about the granulocytes. If you're talking about everything, all white cells, lymphocytes, as well as granulocytes, then you're right. I thought this was just somebody who was neutral.
Okay. And are there any drugs that you could give to increase your white blood cell count?
Oh yeah, there are drugs, GCSF, trade names for it, that can increase white cells. But I think that one would, at some point, if one was going to be looking at that for Temodar, if you go 4, 5, 6 weeks and you're not getting any recovery, I think you get a bone marrow and a hematology look at what's going on, just to see that something untoward isn't happening. The thing I worry about is myelodysplasia, or something else that's been sort of accelerated because of the temozolomide. We don't see many patients who wipe out completely on it, but there are some patients, usually it's more often elderly women, and I'm using elderly in a generous way, being 66.
We're getting up there.
So in any case, I think that there are ways that one can pursue that, but I don't think there are many things you can do to help that, except potentially watch and hope that you don't get a recurrence. But typically, those marrow suppressions are not permanent. They do have marrow recovery.
Okay. Mike asked about Duke's CMV vaccine trial. How's that going?
The newly diagnosed trial, Elevate, has been closed because we hit the accrual we needed. Study, which is using a peptide instead of dendritic cell presentation. It's called Performance, is actively accruing patients. It's unclear yet if dendritic cell vaccines have any advantage over peptide vaccines. They certainly have disadvantages in terms of logistics. You've got to get leukapheresed. It's a more timely and consuming process. If peptide vaccines produce the same kind of immune response, then there's no reason to do dendritic cell. And we do have a CMV trial for using peptides for newly diagnosed patients.
Okay. Here's a nice question. My husband is 13 years out with an oligodendroglioma doing good for years. Do you think it's necessary to still have annual MRIs?
Probably not. Probably not. I think at 13 years out, it depends on what you need for your own reassurance. If you were going to do it, I would do it yearly. If you said, I just don't want to do it for either from a cost or a emotional reason, I don't think anybody would mind stopping at 13 years out.
Okay. Bruce asked, he has an ependymoma. And he's concerned that all the attention is being placed on GBMs and other high-grade gliomas. There's very little research on ependymoma. Do you think much of the research being done now also would apply to ependymoma, and they could use it maybe off trial or off label when it's approved? Or does all the research have to be done over again on ependymomas?
Well, the problem is that ependymoma is a pediatric tumor. It's not an adult tumor. The number of adults who get ependymomas is really, really small.
Well, he's in his 60s.
Right, and so it's so rare in the adult population. You're never going to see a trial. Will you see an extrapolation of the work that's been done? Yeah, you might see an extrapolation, but will it be done as an official trial? No, you're more likely to see people using commercially available drug to try to do it. Right now for ependymoma, the only things we know that works is radiation and surgery. There's no proven benefit for chemotherapy. In pediatrics, that is. And in adults, it's even worse because there's less data.
Okay. Has nivolumab by itself shown any promise for glioblastoma?
No, nivolumab or belimumab, well, nivolumab or Keytruda, same thing basically, two different companies. Those are the checkpoint inhibitors that have not really proven to be a benefit yet.
Running low. Okay, here's an interesting question. My brother is on ABT 414 trial. He had 50% reduction, but he was stable for a long time. So the last MRI saw no change. At what point would you stop, go off the trial, and then do something else? I would look at it and say a 50% reduction that's stable is a good result, right?
Yes, and you won't go on a trial because there's no trial in the world that'll put somebody on with stable disease. That's not going to happen. Now, the question is, how long do you stay on it? Before I would stop somebody, I'd want to know that it wasn't just tumor held in check, that when you stop, it's going to explode. So if I've got somebody that I really don't know what's going on, I'll get not just a PET, because I don't think PETs are definitive, but if it's going to be that big a decision, I'm very likely to get a surgical intervention, a biopsy or resection, to find out what I'm really dealing with. And at that point, if there's still residual tumor, then I think you could consider something different. But I'm not one to stop if there's side effects are trivial and the tumor is controlled.
Okay. Can you explain what pseudoprogression is?
If I punch you in the shoulder, your shoulder is the brain, the punch is radiation, and it's an inflammatory process of radiation damage, can be enhanced by temozolomide in theory, that will basically manifest itself after radiation seminar and then eventually on its own go away. But the question is, well, how do you differentiate pseudoprogression from progression? And you can't. Unless the tumor recurs outside the radiation field, there's no way to differentiate the two possibilities. So the way we approach it is very straightforward. If you come in and you have what looks like progressive disease, but it could be pseudoprogression, and you're clinically intact, we just leave you on Temodar and make the scans over time prove it. If you're clinically getting worse, and we really think we can enroll you on a trial, and we really are more convinced that it's progression than pseudoprogression, we will do that. But typically, you can't do that on a trial. You've got to be confident it's progression, in which case, if we've got somebody who's clinically getting worse, has what looks like pseudoprogression versus progression, we don't know, we add Avastin, because it'll help either way.
Okay. The next two questions are on Avastin. Some people say once you start Avastin, it's dangerous to stop because it might have a rebound effect. And the complementary question is, how long do you usually stay on Avastin?
So I think that if you have a lot of cerebral edema produced by the tumor, then stopping Avastin is indeed dangerous because you can have a real rebound. If on the other hand you don't, I think stopping Avastin is a very reasonable thing to do if there are reasons why you want to stop it. In terms of how long can you be on it, you can be on it for years and years and years. People have stayed on Avastin for 3-4 years, unless they have side effects that preclude them from doing that. Everybody responds differently to Avastin. Again, for us, it's the setting of the patient, the side effects, where they are in life, what they want to do, that influences us with Avastin, much as it would influence us with temozolomide.
Okay. Does anybody use hydroxyurea anymore?
Hydroxyurea was an old therapy that was used for meningioma, and it is on a list of things like interferon, meningioma, RU486. Nothing works for meningioma right now, at least none of the normal agents. There are some people now that are finding certain mutations in meningioma. There may be an Achilles. But short of that, I don't think hydroxyurea gets any play in the brain tumor population.
What are your thoughts on stereotactic radiosurgery for GBMs?
I think it's great for certain settings. Do I think it benefits the newly diagnosed? Never. I don't think it adds anything. I think every study's proven that. Do I think there's a role for it in recurrent disease? Absolutely. I think that there are certain patients, again, with marrows that are very challenged, where stereotactic radiosurgery plays a very good role. We give it with Avastin frequently and then continue with the Avastin. There are patients where you can't do much else because of the bone marrow, again, Avastin. And I think stereotactic radiosurgery has a role. I think stereotactic radiosurgery has a bigger role in brain mets than it does in glioblastoma, even at diagnosis in brain mets. But I think in recurrent disease, there is certainly a role for stereotactic radiosurgery.
In the old days, they used to do high-dose chemotherapy with a bone marrow transplant, and we don't hear that anymore. I guess it didn't work?
Yeah, I have a paper with 50 patients who we treated with pediatric diseases, pediatric tumors, on DIPGs, medulloblastomas, ependymomas, retinoblastoma, trilateral retinoblastoma. I think that the notion that you can make a meaningful intervention with high-dose chemotherapy and stem cell rescue has been diminished over the years. I don't think it has the same place in therapy, and most programs that I know are not doing that, basically because there was never any proof of benefit.
How would you treat an oligoastrocytoma grade 3 differently than a GBM?
An oligoastro grade 3, surgery, radiation, Timodar, unless there was a trial. I'd use the same thing I do for GBM unless there was a clinical trial. And there are not many of those for that tumor combination.
Are you going to go back on 60 Minutes about the polio?
Yes. 60 Minutes has agreed to follow us until registration of the drug, which means FDA approval. We have breakthrough designation, which means a one-arm study, but we're not ready yet. We're not really sure what we want our registration trial to be. Virus alone, virus and CCNU, virus and checkpoint inhibitor. So the next one will be as soon as we treat the first child. We've treated one, but it was not a child where the family dynamics was suitable for filming. As soon as we treat the first child who's filmed, a melanoma patient and a breast cancer patient, we will do another segment of 60 Minutes, hopefully in late fall, certainly hopefully in 2018. And for those who are seeing me, can they see me right now or just hear my voice? They see me?
You and they could hear you.
I'm sorry?
We could see you and we could hear you.
Okay, so what you can obviously tell is that the difference between me now and what happens when I use Scott Pelley's makeup team, hairstyling team, lighting is so dramatic that people don't recognize me in real life, although the hoodie does give it away. I didn't wear one tonight. But there'll be continued 60-minute stories until the drug is approved.
Okay. We touched on this before, but Amy asked specifically, her husband was just diagnosed 2 months ago, glioblastoma. He's unmethylated. He just finished the 6 weeks of radiation and chemo. And that concern, should they just go on the standard of care with Timodar even though she's unmethylated?
If the patient has not yet started Timodar, they would be potentially eligible for performance, which is the CMV peptide study. Unlike Elevate, you had to do the pheresis consent before you started radiation. Performance lets you go on to the study as long as you haven't had the first monthly Timodar. But there's a catch. You have to have CMV seropositivity. You have to have been exposed to, contracted, and reacted to CMV, and only half the population has CMV antibodies in their blood. So if this just really happened, the rush job is to call us at Duke and let us see if this is a possibility. I'm not even sure performance is open right now, but by the time someone came, it might well be because the study's open and they close.
Somebody asked for your contact information. I'll put it online, but you could give it right now.
The best number probably is 919-668-2650.
One of your patients says he just hit his 3rd year on Optune now, doing great.
Good.
Good question. He just wanted to say hello. We're running low on questions. I'm just going to check Facebook. I've been
I'm
checking.
not on Facebook. I'm not on LinkedIn. I have a Twitter account that I've never sent but one tweet, and it's so inappropriate that my daughter and my family took it off of me because I told some people we were away from Hilton Head, which is where we have a vacation home, and it was a Hurricane Matthew, and so we weren't there. But could somebody just let us know if the house was okay? And it was sort of like saying, "Please rob me now." And so my family said,
That's true.
and I said, I don't know how to take it down. So they took it down for me, and I've never sent another tweet in my life, but I follow 17 people on Twitter, and 72 follow me, but they'll never be anything to see because I don't send tweets. I got scarred by that memory.
Well, you're live on Facebook right now.
Well, that's fine, but I won't be able to check it myself.
Um, does most GBM research apply to anaplastic astrocytoma? We asked this with a different type of tumor before.
Well, in a way, if something works, it's more often than not going to work better in anaplastic astro. Always, but typically I think of things that if they work really well in GBM, they're going to work better in AAs. And that's been my experience with the different therapies we've used.
Somebody with a GBM recurrence, how would you treat methylated versus unmethylated GBM recurrence? What would be your first choice?
Doesn't affect me. The methylation status is irrelevant to me unless it involves protocol enrollment. If protocol enrollment is not an issue, I don't pay attention to the methylation status.
Okay. Is there any progress in understanding the origin of gliomas, and do cell phones have a link?
Okay, so the cell phone question I've addressed many, many times, and there is no compelling data that says that a cell phone, I gotta take this call, wait a minute. It says a cell phone is really a problem. No data at all. Just like power lines and childhood leukemia and things of that sort. So I don't believe that there's any meaningful data that says that non-ionizing radiation, EMF, whatever, is going to be a cause of a brain tumor. What was the first part of the question?
That covered it.
Okay.
Are you a fan of high-dose vitamin C infusions?
No, I think the problem with high-dose vitamin C is that's an antioxidant. And a lot of the therapies we use do damage to the DNA of the tumor through oxidation. So we tell our patients, if you want to use alternative medications, we want to know what they are. And if you're going to use Cyc-T or Cancel, or you're going to use melatonin or vitamin D, or you're going to even use valganciclovir, we may not think it has merit, but we're not going to be saying, you can't do it. If you're talking about Laetrile, which came from apricot pits, which contain cyanide, or even worse, antineoplastons, we have very aggressive feelings that that's simply not going to happen. Vitamin C is sort of in between. We don't think it's toxic. You just pee it out. But we think it could undercut therapy.
What about diets like the
Ketogenic.
ketogenic diet?
There are several papers that have come out in the last year saying no proof that a ketogenic diet does anything to help somebody. And it certainly cheapens the quality of life. And so I think that people with any disease, healthy people, but people with any disease, deserve to maximize the quality of their life. And a ketogenic diet doesn't do that. We definitely do not support ketogenic diet because there's data that clearly says there's no answer yet.
How about the people who keep saying eating sugar feeds the tumor, and they try to cut out all sugar?
I would tell you who they probably voted for, but then that would be inappropriate. So suffice me to say that you can't starve a tumor. Cannot be done. You should eat based on a healthy cardiac diet. So, you don't want to go out there and live at the fast food places, but I don't think you can starve a tumor, ever.
Okay. Is there ever a time when you would say that glioblastoma is cured?
Well, I think when we've got patients that are 5, 6, 7, 8, 10, 15, 20 years out now, which we all at the major centers have, I think they're cured. Especially when you're getting into the 10 to 20 year range. I think patients are cured. The question, though, is it something that a medical team did or not? So I want to tell a story. I had the privilege and the honor of working for 18 years as a mentee, being mentored by Gertrude Elion, one of the giants of our generation, who synthesized 6-MP, 6-TG, allopurinol, acyclovir, AZT, won a Nobel Prize and was just a brilliant woman. 6-MP was a drug that was one of the early drugs in childhood leukemia. And when people took it, children took it, about 90% went into remission, and almost all of them came out of remission in 6 months. When she won the Nobel Prize, she got a series of letters from people saying, I was diagnosed 25 years ago with childhood leukemia. I took 6 months of 6-MP and I was cured. So in those patients, every leukemia cell must have had a susceptibility to 6-MP, which they would not have otherwise been able to survive. So I think that there are people who are surviving GBM, not necessarily because of what we're doing, but because of a unique genetic propensity to be responsive to therapy. Unfortunately, we don't have enough data. This is stuff that you've talked about, Al. If we could track these patients, we need to know the commonalities of why long-term survivors are long-term survivors. And no one's talked about that more compellingly than you, the need to track longitudinally patients who are treated.
That's true. Okay, and the last question, we're just about out of time. Do you see any major breakthroughs coming in the next few years?
I would hope, without being self-serving,
Yes, fire.
it's going to be a major breakthrough. I think that there will be other immunotherapies that I hope and pray are going to be meaningful for this disease, because I think unlike targeted therapy, where you've got to have a certain mutation and you hit those cells, but other cells emerge, immunotherapy is just hitting the tumor cells in general that happen to have the mutation. If they all have the mutation, like for polio, they just have to have a receptor, and all tumor cells, all solid tumors, except Burkitt's, have that receptor. So I've got a lot of hope in that. And since I never intend to retire, health willing, and my wife told me that if I did, she'd put me in a nursing home, and she's never going to retire. She's doing hotter stuff with stem cells and cord blood. I am hopeful that we will indeed see in the next 5 years some dramatic changes in the outcome of this disease.
One last question that just came up. In that 60 Minutes episode, they talked about like the second or third patient dying from the treatment because of excessive swelling. Has that been controlled now? And that's not a problem anymore, is it?
Okay, so that would have probably been episode 2 in 2016, not 2015. The 2016 episode had that patient. And I believe that because we've learned that unlike in chemotherapy, more is not better. We've dose reduced in polio to what we know now is to be the appropriate dose. And we also know that if we jump in early with sort of a mid-range dose of Avastin, we can really preclude the kind of swelling that we couldn't control before. And we were using steroids, producing such severe toxicity that patients basically wanted to just stop therapy, as was the case with that patient.
Okay, perfect. And that concludes our webinar for this week. Next week, Sunday, May 27th, we have Dr. Eric Wang from the Brain Tumor Center at Beth Israel Deaconess Medical Center.
Wait a minute. I'm not the only one doing this. There were other people?
We had 4. You're the third one.
Okay, are we going to vote at the end who was best?
Oh, we could do that. This was a lot of fun.
All right, everybody. It's a
Thank you so much.
Al, always a pleasure.
Okay, thank you. Bye-bye.
Bye-bye.